for your kind introduction, and thank you to the organizers for giving us the opportunity to come here and present some of our work and discuss some cases. So the idea behind today's talk is to talk about anemias. So not all anemia is nutritional anemia, and it's not always a straightforward diagnosis. So I'll be discussing some of the aspects in a case-based manner, just some basics about how we do the CBC, what are certain things that need to be kept in mind, and then we'll straight go to various cases and see how to approach them. So my apologies for the delay. This microscope was invented by Sir Andrew von Dhingra, and that really changed the way the world looked at red blood cells and the various blood components. Then this other significant advance that happened was when Sir Wallace Coulter gave the Coulter principle, based on which all the modern day CBC analyzers work. So when we look at various parameters of CBC, there are approximately 33 parameters that can be taken out. Some are directly measured, some are calculated from a CBC analyzer. But what are the important parameters? So the ones that are directly measured by a CBC counter. So you must have heard sometimes that there is a 5-part differential or a 3-part differential. So when we talk of a CBC counter that you might have in your hospitals, in your labs, so what we want is, we want a 5-part differential, a counter that gives a 5-part differential, which means that it can count the red cells, platelets, WBCs, and give a 5-part differential of the WBC, which includes neutrophil, lymphocyte, monocyte, basophil, and eosinophil. That is the bare minimum of performing a good CBC and having a good differential count, through which an accurate diagnosis can be made. So certain parameters that are directly measured include your hemoglobin, RBC, and WBC count. The reticulocyte count, modern day CBC analyzers can count directly. Derived through histograms via the Coulter principle include the MCV, red cell distribution width, the differential lymphocyte count, which is derived through variations in size and the granularity of the various types of WBCs, and the platelet distribution width. Then there are certain parameters that are calculated, which include the hematocrit, the MCH, and the MCHC. So key parameters which we take into account while doing a CBC. Can we dim the lights, please? The lights of the world. So the key parameters that we look at while making a hematological diagnosis are, of course, the hemoglobin. When we talk of anemia, the MCV is very important. The red cell distribution width is very important. The RBC count is important. And of course, we have to establish whether it is an isolated anemia or there is more than one cytopenia or pancytopenia. So the platelet count and WBC count and differential are also very important. But one thing that every clinician must keep in mind is that when you are interpreting a CBC, we should always interpret it with respect to the reference range, which can vary depending upon age. So the reference range is different for children than it is for adults. It also varies depending upon the racial or the ethnicity profile. So sometimes at max we get patients from Africa where naturally the absolute neutrophil count is low. So we should have our own. If we talk of Indian population, we have the reference range for platelets as 1.5 to 4.5 lakhs. But this reference range is derived from US-based population. And you will get a lot of concerns from patients who are very concerned about marginally reduced platelets. Somebody who has a platelet count of 1.25 lakhs, 1.3 lakhs. In India, there are a lot of populations in the eastern parts, Jhansi, even Bihar, the eastern part of the country, where the platelet counts are low by birth, but they are normal, Jammu and Kashmir. So for the Indian population, a platelet count between 1 to 1.5 lakh is also normal. Only if it is less than 1 lakh, you should consider it as a low platelet count. So one thing, when we start looking at a CBC, we need to interpret it with the right reference range. So age-specific indices are there. So going into, if we start from pediatrics, sometimes you get worried parents, they bring the CBC, they are very anxious that the CBC is not normal. But we need to remember that in children, normally there is a lymphocytic predominance if we look at the WBC differential, and they reach the adult reference ranges anywhere between the age of 7 to 11. So knowing these correct reference ranges is often the first step in making a proper diagnosis. Then there can be some sources of error in the CBC report. So the sample collection has to be a free-flowing sample which is collected But if you're doing coagulation studies, we have to preferably the patient has to be calm. Any kind of stress can alter the coagulation test. So the sample should not be hemolyzed, it should not be lipemic. Sometimes if there is a paraprotein, doing the CBC becomes difficult. Cold agglutinins, it should not be clotted. If it's clotted, then if you put microclots are there, you run it in the analyzer, you'll get all haywire values. So the sample collection has to be very good, it has to be done very properly. So now moving to the focus of today's talk, that is anemia. So broadly when we talk of anemia, it means that the hemoglobin is less than 2 standard deviations for that age and sex for that population. And we classify, the easiest way to classify anemia is whether it is microcytic, where the MCV is less than 80 femtoliters, macrocytic when it is more than 100, or normocytic, which is one of the largest groups where the anemia is between 80 to 100 femtoliters. Most of the critical care consults or hospitalized patients consults that we get for anemia, they fall into this category, where the anemia is often multifactorial. So when we talk of microcytic anemia, so one thing, so there are certain causes for microcytic anemia. It's iron deficiency being most common in our population. Then in northern India, thalassemia minor is very common. Anemia of chronic inflammation, if long-standing, can also lead to a microcytic anemia. Lead poisoning. We recently had a young woman, fashion designer, exposed to a lot of dyes, who came with abdominal pain and anemia, and it turned out to be that she had lead poisoning. Sideroblastic anemias, which are congenital sideroblastic anemias. Now, often when we start the evaluation of somebody who has a microcytic anemia, where the MCV is less than 80, we look for iron deficiency. So one thing that I'd like to highlight over here is that when you're checking for iron deficiency, the single most important test that needs to be done is a serum ferritin. So we often do iron studies, which can be falsely elevated if a lot of times patients are taking oral iron supplements. So when somebody is taking an oral iron supplement, then the serum iron studies will be falsely normal. And if you do a ferritin, you will see that the ferritin is low and the patient is actually having iron deficiency anemia. So we have various cutoffs. For pregnancy, we have cutoffs of less than 30 as given by various international guidelines. And a lot of times I get iron deficient pregnant females where the gynecologist is very scared about giving IV iron. So NC-carb is being studied and it has been found safe to be given from second trimester of pregnancy onwards, and it should be given for most adult patients suffering from iron deficiency anemia. Oral iron, the dose and the duration for which it needs to be taken is very difficult. So nowadays, the standard recommendation is that if you have an adult patient with a low serum ferritin, we should advise IV iron. A single dose of ferric carboxymaltose is good enough to correct, but we should not stop there. Any adult with iron deficiency anemia, if it's a woman and it's not a heavy menstrual loss, any adult or postmenopausal lady or any adult male, please do refer to a gastroenterologist. A thorough gastro evaluation must be done to look for the cause of blood loss, because that is most often the culprit behind the iron deficiency. So the key point is microcytic anemia, of course iron deficiency being the most common. First thing to do, check serum ferritin. If serum ferritin is low, it is iron deficiency anemia. If it is normal or elevated, then other possibilities are we should do a hemoglobin HPLC. It could be a thalassemia intermedia or thalassemia minor syndrome, or it could be some form of chronic inflammation because of which the ferritin is elevated. Sometimes iron deficiency and chronic inflammation can coexist. So if you have a low serum iron but the ferritin is less than 100, it is in the normal range but it is less than 100, then often it is in a patient who has, say, rheumatoid arthritis. So it's a combination of factors. Both anemia of chronic inflammation and iron deficiency are coexistent. For such patients, IV iron should be prescribed. They will not absorb oral iron because of the inflammation. Then moving on to macrocytic anemia. So macrocytic anemia can be most commonly, again, predominantly vegetarian population, and we do have a lot of malabsorption for vitamin B12. So me being a very ardent non-vegetarian, I still have low vitamin B12 levels. So vitamin B12 and folate deficiency is it's a macrocytic anemia. Other causes can be drugs. So anybody who's on anti-HIV medications, hydroxyurea, these are some of the drugs that cause macrocytosis. Liver disease can have mild macrocytosis. Then primary bone marrow disorders like myelodysplastic syndrome, where there is a stress erythropoiesis, there will be macrocytic anemia. So whenever you have a macrocytic anemia, so we have to rule out any kind of drug intake, we have to rule out B12 and folate deficiency. So if we find B12 and folate deficiency, we have to correct the deficiency. If it's not vitamin B12 deficiency, we have to look for other cause. A well-performed peripheral smear examination is required to rule out MDS and other serious blood disorders. One practical tip that I'd like to share with you is that when the MCV is very, very high, when it is in the range of 140, 150, that means that your red cells are getting agglutinated. They are forming clumps, which is getting picked up as a very, very high MCV. So that is a pathognomic feature of a blood disorder called cold agglutinin syndrome, which is common in elderly. So we have to consider that. If your MCV is somewhere between up to 120, 130, then megaloblastic anemia or macrocytic anemia due to B12 folate deficiency is the most likely cause. If the MCV is high, but between 100 to 110, mildly elevated, then do consider that it could be a primary bone marrow related disorder which leads to a stress erythropoiesis and macrocytic RBCs. So this is one practical tip that we follow in our day-to-day practice. Then one of the largest groups that we see is normocytic anemia. So normocytic anemia again could be a nutritional anemia. So it could be a combined deficiency of B12 and folate. You have both populations of macrocytic and microcytic cells. So the average becomes normocytic. All hemolytic anemias, because some cells are big, some are small, they average out and they are normocytic range when we look at the MCV. So we should look for a reticulocyte count, LDH, haptoglobulin. We should rule out underlying hemolysis. And then anemia of renal insufficiency is often normocytic. So one of the things that we must consider if we have a patient who is presenting with normocytic anemia, who has renal dysfunction, is multiple myeloma, which is one of the most common blood cancers, especially in the elderly population. So please do look at the liver function test. If you see that the globulin fraction is markedly increased, that could point to an underlying M protein. So a serum protein electrophoresis a lot of times is diagnostic in such situations. So two parameters, again, anemia, there are various ways to classify, but MCV and red cell distribution width are very frequently used to find out, to basically identify the cause of anemia. So MCV, if it is low, and your red cell distribution width, which is basically a marker of red cell anisocytosis, which means that what variability in the shape of red cells is there. So if you have low MCV and the red cell distribution width is high, then it means it's an iron deficiency anemia. If you have a low MCV but the red cell distribution width is normal, then it is usually a beta thalassemia minor. This also forms the basis of something which is very commonly used and very popular, that is called Benson index. So if you have a normal MCV and an increased red cell distribution width, inflammatory anemia is what we need to think of. A high MCV with a high RDW, again nutritional, so megaloblastic anemia. But a high MCV with a normal red cell distribution width, again this is one scenario where a primary blood disorder should be thought of. There is another important but very basic test that needs to be done while evaluating anemia is a reticulocyte count. So a reticulocyte count is done by a process of supravital staining. Now a lot of modern cell counters do it automated, we do it manually also. So when you do a reticulocyte count, two things need to be taken into account. That one, you have to correct the reticulocyte count that you are getting for the degree of anemia. So if somebody's hemoglobin is 5 grams, then and the reticulocyte count is 12%, you have to correct it for the degree. So you have to do this calculation and find the corrected reticulocyte count. So moving on from after these basics, we will be discussing some cases. So this is a 9-month-old girl who is exclusively breastfed. It could be anybody, it could be a teenager girl who comes to you with pallor. So she has anemia. If we look at the MCV, it is 57, so it's a microcytic anemia. The TLC and the DLC are largely normal for her age. The platelet count is elevated, so it's 5.5 lakhs, and the RBC count is 2.14 million. So any guesses from the audience, what are we dealing with here? What is the cause of anemia? It's a microcytic anemia, microcytic hypochromic anemia. The MCH and the MCHC are low. Platelets are slightly high and HB is 6.4. Any guesses? So it's an iron deficiency anemia. I'm going to keep it very simple. So why I'm saying it's an iron deficiency anemia, I'll just explain it to you. So first of all, the hemoglobin is low and it's a microcytic hypochromic anemia. The MCV was 57 and the MCH and the MCHC were low. And red cell distribution bit is increased. What I think was the confounding fact was that the platelets were slightly high. So a lot of times when you see iron deficiency anemia, the platelet count can be on the higher side. So that is one of the features of iron deficiency anemia, that when there is iron deficiency, there is release of thrombopoietin also, which stimulates the platelet production. The bone marrow is under stress and therefore the platelet counts can be slightly high. So that please don't let that confuse you. High platelets can be seen in iron deficiency anemia. Now we move on to another case. This is a 5-year-old girl with mild anemia. Her HB is 9.4. The TLC and the DLC are normal. The platelet count is normal. Again, it's a microcytic hypochromic anemia. The MCV is 60. The RBC count is now on the higher side. It is 6.14 million. So now what we are dealing with? Yes. So now in this particular scenario, the most likely etiology for her anemia is a thalassemia minor. So iron deficiency anemia and thalassemia trait we often need to distinguish. But one myth, very common myth that we encounter is that people assume that people who have minor thalassemia or thalassemia trait, they cannot develop iron deficiency, and they are often prescribed iron restricted diets. That is absolutely not necessary. Thalassemia trait, they are not at risk for iron overload. They should not get iron restricted diets. They can have iron deficiency anemia. So ferritin and the hemoglobin HbA1c both should be done, because somebody with a thalassemia trait can have IDA also. So when we talk of iron deficiency anemia, the severity of anemia can be mild to severe. In our country, we can even see patients with a hemoglobin of 3 and iron deficiency anemia. But in thalassemia trait, the anemia is often mild, so 9 to 10 gram per deciliter. And boys with thalassemia trait, they do better, because when they hit puberty, they have their male hormones, so they can go up to 12-13. A normal young healthy male can have a hemoglobin of 15-16 also, but a thal trait can have 12-13 because their male hormones help them. So in thal trait, you will always have mild anemia. The red cell distribution bit in thalassemia trait, all the RBCs are going to be of the same size, so it's not going to be increased. But in iron deficiency anemia, it will be increased. The RBC count is an important clue to diagnosis. So if you have somebody, normally the RBC count is 1/3 of the hemoglobin value. So at a hemoglobin value of 9, the RBC count should have been 3. But for this kid, it was 6. So disproportionate erythrocytosis always points towards a thalassemia trait. The platelet count, as I mentioned, can be increased in iron deficiency anemia. Benzer index is something that we calculate. MCV divided by RBC count in million is more than 13 in iron deficiency anemia and less than 13 because the denominator is high in thalassemia trait. Then of course your iron studies would be low in iron deficiency anemia. HbA1c would clinch the diagnosis. But the key message is that thal trait can also be iron deficient and they don't need iron restricted diet. So another case, a 13-month-old boy with recurrent blood transfusions, hepatosplenomegaly, severely anemic. The TLC is very high, 22,600. Platelets are normal. Severe microcytosis, the MCV is 54. So what is the likely diagnosis? And it's very common in this part of the world. So here in Jhansi, you see a lot of thalassemia. So this is a classical thalassemia. Now, if you will ask that why the TLC is very high, it is getting falsely elevated because of a lot of nucleated red cells being released. So always if you are getting a picture of thalassemia and you feel, sometimes we do get patients where there is a thought that is it a leukemia, is it a JMML? No, this is thalassemia. A smear examination and correcting the TLC for the NRBCs will give you the actual corrected TLC. Then we have another boy with progressive pallor, no hepatosplenomegaly. So again, severe anemia 5.6. Now the MCV is 114. If you look at the RBC count, it's very low. It's 1.7 million. There is mild neutropenia also. The neutrophils are 34, lymphocytes are 56, TLC is also low. So basically there is pancytopenia and the MCV is high. Any guesses from the audience what this boy has? Megaloblastic anemia is the correct answer. So we should look for B12 and folate levels. So megaloblastic anemia can present with pancytopenia. Anytime we get somebody with anemia, we must look at the TLC, we must look at the platelets, and we must look at the WBC differential, which is very important. So there can be various causes of pancytopenia, nutritional being very common, any infection. Aplastic anemia, we must do a reticulocyte count. If it's very low, it shows that the bone marrow is not functional. It could be a malignancy, so a well-performed peripheral smear is important. Any drugs, a lot of time patients who are taking treatment for rheumatoid arthritis, they tend to sometimes wrongly dose themselves for methotrexate. We do get 3-4 patients every year who have methotrexate-induced bone marrow suppression. So that identification is very important. It could be immune-mediated, so autoimmune disorders, especially in young women, we have to consider for pancytopenia. Hypersplenism, anybody with a CLD is likely to have low blood counts. Then there can be some rarer causes which are primary hematological causes.
Nivedita, we
have to wind up?
Yeah.
So I'll quickly just take the remaining cases, there are just 1 or 2 left. So this is a 45-year-old male and just weak and dyspnea on exertion, and there was no organomegaly. So if we look at the CBC, we see that the patient has anemia, the MCV is high, the red cell distribution width is high, the RBC count is very low, and the MCH, if we look, it is very high, MCH and MCHC. So 47 MCH is very, very high as per the normal ranges, and MCH is usually around 27, MCHC is close to 40. So when we did a peripheral smear, we found something that we just discussed, that this patient had a lot of RBC agglutination. So this RBC agglutination is actually gives the clue to the entire diagnosis. Somebody presenting with an anemia, a high MCV, and you find such RBC clumps on the peripheral smear. There were other markers of hemolysis also, like NRBC, polychromatophils. The retic count was very high. So after you warm the sample at 37 degrees Celsius, the agglutinates, they disappear and you get a normal smear. So in such situations, transporting the EDTA sample to the lab in a simple warm water bath would help in differentiating that what is happening. So if you warm it at 37, you see that the smear becomes normal. You also had other markers of hemolysis like a high unconjugated bilirubin, low haptoglobulin, high LDH. So basically what this patient had was a cold agglutination was happening. He had autoantibodies of the IgM subtype which were causing these RBC agglutinates to form. Generally these antibodies, they get activated at acral parts of the body like your fingertips, your earlobes, your nose tip. Here they bind, if you remember in immunology, IgM binds complement. So these IgM antibodies, they bind to red cells, they activate the classical complement pathway, and complement mediated cell lysis happens. So basically this is one situation where a complement mediated lysis will happen via the IgM antibodies. If we encounter such a scenario, these antibodies could be idiopathic, but underlying lymphomas, autoimmune diseases, then mycoplasma infection, mycoplasma serology must be done, because in those scenarios it would be self-limiting. However, if we find that nothing, we should do a bone marrow, PET scan, flow cytometry. The treatment, often such patients give a history of Raynaud's phenomenon and livedo reticularis. So in this scenario, what must be done is first we need to warm the sample and do the testing so that we can identify the antibody. And in such a situation, if we give rituximab 4 weekly doses, there is an 80% response rate and patients attain a long-term remission. So the next case that I was going to discuss, but I'll quickly rush through, is something that Sengher sir also took up in his talk, is something like TTP, where you have somebody presenting with neurological symptoms and bicytopenia, anemia and thrombocytopenia. This is a medical emergency, so this is one of those hematological emergencies where a good peripheral smear showing these broken cells called schistocytes clinches the diagnosis. We cannot wait for the confirmatory results to come. We need to start urgent plasma exchange, steroids, and sometimes even rituximab. So basically, we often in our traditional teaching, we think that a pentad of microangiopathic hemolytic anemia, thrombocytopenia, fever, neurological symptoms and renal insufficiency should be there. But this is actually present in less than 10% of the cases. More often than not, we have a triad, but even a dyad is sufficient if you are finding schistocytes and you need to start treatment. You need to look for any underlying predisposing condition like any autoimmune disorder, infection, cancer, which is triggering this TTP. But immediately what needs to be done is a plex and you need to start steroids. For patients who have cardiac and neurological symptoms, even rituximab weekly has to be given. 95% of the cases, this TTP is an acquired TTP where you get an antibody to Adam's TS13. In 5% cases, it could be hereditary. So, last, this is just like a quiz question and then I'll end my talk. So, this is a 28-year-old male who presented to ER with a history of phenol ingestion, was found to have acute kidney injury, passing cola-colored urine. The hemoglobin was low, he was having florid hemolysis with a high LDH, high retic, low haptoglobulin, very high bilirubin, which was predominantly indirect. So any guesses that with such a urine, what are we dealing with? That could be one possibility. This is a real case, so any other guesses? I think Sir also touched it during his talk, this also. A male patient presenting after phenol ingestion with acute hemolysis. So he was G6PD deficient. We did a G6PD. This was intravascular hemolysis where all the red cell breakdown, normally in hemolytic anemias like any condition like hereditary spherocytosis or any other autoimmune hemolytic anemia, there is extravascular hemolysis which occurs in the reticuloendothelial system. There are very few causes where the red cell destruction occurs predominantly in the intravascular compartment and that leads to hemoglobinuria. G6PD, PNH, these are some of those disorders. So the characteristic peripheral smear finding, if you look at some of the red cells, it seems that something has bitten off. So these are bite cells which are pathognomic. Again, a good PS is confirmatory. So this is our team and thank you for your patient listening. I'd be happy to take any questions.
Thank you so much, ma'am, for this lucid presentation. I request our honorable chairpersons to please felicitate us.
Wait.
I request our honorable
हो गया?
speaker, Nivedita ma'am, to kindly present a head.
रुक के रखना है.
I request her to kindly felicitate Dr. R.R. Saxena sahab. Request to kindly do a honor to Dr. M.S. And of course, Dr. Gupta sahab also. With honor.
ठीक सर.